Could you tell us something about the advantages of prosthesis based on implants?
Well, it's actually when people have to wear prostheses that are not fixed to implants, they have always difficulty with chewing, it's social difficulties. It makes them function less than they want to function. And this is what we call the oral health related quality of life is increasing tremendously when you stabilize a prosthesis with implants.
And you are presenting the protocol on 4 implants. And could you tell us why not 6 or 8?
Yeah, what we were looking for in the past was a solution for edentulous people that was affordable, easy to make, didn't need augmentation procedures. And we met Palomalo, and he was introducing us to the all-on-4 concept, finally resulting in what we call the FAVE concept, the fixed full arch immediate functioning solutions. So.
And how we should choose the patient for this protocol? Or is everyone a patient that we can make this protocol?
No, that's never the case. You always have to select your patients carefully because you don't want to end with disappointments. So it's important that they are in good health, preferable not non-smokers, but we treat smokers as well.
Bone volume. Of course, the maintenance of the patient. So we have to select carefully patients who have good oral health and who have a good protocol in cleaning their implants or prostheses. So that's one of the important things. And so it's right what Hans says. It's not for everyone. So you have to be very you have to look very carefully which patient you choose for this treatment.
Mm-hmm. And how about the dentist, implantologist? Is it the protocol for beginners or for advanced?
Well, we are always beginners in the beginning. And when you start to get familiar with the system, then you are not a beginner anymore. So if you choose your patients carefully and you know that there is enough bone, then even a beginner who has had a good preparation will be able to perform this operation.
And what tools do we need to proceed this protocol? What tools do dentists or implantologists need to plan, for example?
I think for the planning you can do your normal orthopantomogram, but if you want to have a really good help, then I would do a CT scan. And if you do a CT scan and you can see that it's a complex case, then you even can do this whole concept in a guided way. So we can then make a drilling guide which guides our drills and our implants into the right position. So, but that is really something for the advanced implantologists, which in complex cases.
What is also important is the smile line of the patient. When you have a lot of bone still existing in the mouth and you have to perform the all-on-4 concept, you will end up with a patient that you are looking underneath the prosthesis. So when he raises his lips, you will have a look at the connection between the mucosa and the prosthesis, and that will end up in an aesthetic disappointment. So you have to know with this kind of smile line where you are ending.
When we can choose a bridge based on implant for our patient, and when the best solution should be the prosthesis on implant?
Yeah, well, the moment you take out teeth from the jaw starts to resorb, and you are losing a tremendous lot of bone in the first year. So, after 1 year, you will have a third left of the original jaws. So, if you have a patient that lost his teeth a long time ago, there will be not a lot of bone and not a lot of mucosa, and you don't only have to compensate for the missing teeth, but also for the missing mucosa. And then a fixed bridge is difficult to make. You have to add pink porcelain or acrylic, and that's not always a good solution. So in that kind of cases, the faith concept is more easy to apply on those patients.
How to copy the function, the range, and the aesthetic of the existing prosthesis when the patient used to wear, and the new prosthesis based on implant. How we can do this? What steps should we make?
I think that's a good question. We never copy the prosthesis, so we just make the whole concept new, because if we have patients who were used to wearing a loose prosthesis, there was wear in every way, so I wouldn't copy it. What you can do is you can make a new prosthesis, so a new situation, and give that to the lab, and then they transfer it to an eggshell prosthesis, which you can use to make an impression when the implants are placed in the jaw. On the other hand, if you are doing a guided way of placing the implants, then in advance you can already make your prosthesis and screw it on directly, because the discrepancy will be very, very little between the model and what's in the mouth of the patient.
And what do you think about the digital world? Is it ready to go step by step from the beginning, from the planning until the final restoration? Where are we now?
We already did in the start of the century planning where to place our implants digitally, and that is even become better and more accurate at this moment. Digital impression making of large bridges and implants is a bit more difficult, because that's not accurate enough. So you can use it for planning, and you can make a drill guide digitally, but not impression taking for whole full arch situations.
And occlusion is always a big question, and the most important topic for the bridges and the prosthesis. How do you think how we can make the occlusion stable, or what are the possibilities to control the occlusion after several years, when we finish the case, when the patient is already wearing the prosthesis or the bridges?
I think we always have to monitor occlusion, because occlusion is very important. So therefore I think it's important that patients are in the recall system. So they have to come back every year, every half year, it all depends on the patient, to the office. The occlusion concept of a fixed bridge is a different concept than a prosthesis, a loose prosthesis. So in the fixed bridge we have a contact all over, and in the prosthesis that changes. So we like to have an occlusion concept where we have contact all over the bridge.
And do you observe the changing of the occlusion during the years?
What you see is that there is a lot of wear on those fixed prostheses, on those on four bridges, faith bridges, and we tell our patients in advance that they have to have new teeth on their existing prostheses, on their existing bridges every 5 years. Because of the wear and because of the strange things that will happen to occlusion and articulation when you do not do anything against this wear.
So it means that using acrylic or some kind of plastic reconstruction, we are more physiological than strong porcelain based fused on metal.
That's absolutely true. And another big advantage is if you are using acrylic teeth, you always if there is a prosthetic problem, you can help the people very fast with the problem. If we have porcelain, then it always has to go back to the lab. It has to go back into the oven. There is always heat and there will be shrinkage or whatever. So it's better, in our opinion, to use acrylic teeth on an acrylic basis around a titanium or PEEK or whatever basis.
Could you add something?
Yes, I think that the worst thing you can do is make a porcelain bridge in the upper jaw and make another porcelain bridge in the lower jaw, and let them articulate on those bridges. You will see those patients back every fortnight.
Are any limitation for reconstructions if we have in one arch, for example, prosthesis based on 4 implants? What we can have in opposite arch?
Oh, you can also make a prosthesis or a bridge fitting on 4 implants in the opposite arch, but do not make 2 porcelain bridges, one in the upper and one in the lower. Then what we do in our clinic is we make a porcelain bridge in the upper jaw, or a zirconium bridge, or porcelain fused to zirconium, and in the lower jaw we make a acrylic bridge.
Is your protocol prepared for lower and upper arch? The protocol based on 4 implants?
Yeah, it functions in both jaws. There's no problem.
Yeah, I think so too, but you have to understand that it's not our protocol to make all 4 bridges, 5 bridges with all our patients. If they don't need full arch reconstructions, then there are other possibilities for treating them as well.
Mm-hmm. And what do you think about the immediate loading? Is it really an immediate loading that we gain a lot? What do we gain in this game?
I think you gain a lot. The patient gains a lot because people who want to have this fixed in one day are mostly people who are working either in the public work or are businessmen who travel all over the world. So the immediate concept works in all those cases. And why should we delay the case if it works? I don't see any advantage of doing not an immediate protocol.
For patients, it's very nice to come into the office in the morning with your remaining teeth, of course with troubled remaining teeth, and leaving the office in the afternoon with new teeth that are fixed to implants. And another advantage can be it's like when you are building a fence around your garden. You start on one side, and then your wife comes and she does like this with the fence, and she tells you, shouldn't we ask the carpenter to finish this fence? And then the moment you start to build the fence around the corner, the fence becomes rigid. And that's the same with immediate professionalization. You build your implants around the corner, you unite them with a rigid structure, and then there will be very little micro motion.
And how about the risk? What do you observe in your practice? How it look like the failures?
Failures? Oh, I don't have failures. He does.
I'm the only one who has failures. No. I can say we don't have too many failures. So of course we have failures, but on the other hand, we did cases where 3 implants were stable and 1 wasn't stable. But through the cross-arch plinting, what we are doing, the one which wasn't stable was stable by means of the other three. So it osseointegrated in a really good way. So it was, after 4 months, it had an ISQ value of over 60. So then you have really a stable implant again. The only problem you can have is if you place the implants, if you go over the 45 degrees angle, and then you can encounter problems.
So what we can say to our patients about this protocol, how we should inform about this protocol and another, let's say, protocol based on 6 or 8 implant, how patients usually ask, is it risky, is it safe, it's fast, what I can gain? So.
Well, the reason we choose for 4 implants is because of financial backgrounds. 4 implants are more cheap than 6 implants, or 8, or 10, or 12, whatever. But it still is a problem the moment we start losing implants. Then we only have 3 left, and it's like 10. You know the story about 10 little Negroes.
Where the dentist should be in this situation, how we can help the patient to go through this problem, because it's usually the dentist's problem, not the patient usually.
Yeah, well, that is perhaps a different here in Poland and with our clinic, because we do both the implant surgeries and we do the prosthodontics. So the problems with the prosthesis or the fixed bridges are our problems as well. What you should do is develop a careful protocol in maintenance, and the moment you see that there are problems going on, then you have to go back to the surgeon and find a solution for that, the two of you together.
Okay, and the last question: do you think that 2 implants in mandibular should be, let's say, available for all the elderly people? How do you think? Maybe through the social system? Or?
That's a simple answer. In our country, it's paid by the government.
A loose prosthesis in the lower jaw is really a problem for patients, and what you can do with 2 implants and a bar is change that situation into what's very nice for people. Because of the system in Holland, we have done hundreds of cases like that, and we have never had a patient coming back to us and tell us take them out because I don't like them and I don't want them anymore. They are all very happy with that.